My name is Dr. Jeremy Bruce. I'm a general practitioner and I work for the NHS. If I was doing a full day's work, I suppose I would see up towards maybe 40 to 50 patients. Obviously telephone consultations may come into it, and also you may be asked to part consult on a patient already maybe seen by a nurse or even possibly another colleague. I think because we are so focused, certainly in the Western world, on physical ailments, almost everyone will present with a physical illness. I suppose in some ways the skill of a general practitioner is to always be looking for that hidden agenda. People will quite often use the physical ailment as their key, if you like, their pass through the door to see a doctor. But of course the key is to listen to the patient and sort of try and unravel possibly the real reason why they've come in the first place. I'd have to say that mental health training, if I go back to medical school, one did a psychiatric attachment, but this was really only a relatively short time. From memory, I think of maybe sort of 3-month attachment, but of course that is within the hospital sector, if you like. Obviously in general practice you're working in primary care, and there was no, I'd have to say there was actually no specific training for primary care mental health issues. A lot of things that one learns as a doctor you learn osmotically, obviously your usual casual reading for sort of personal development plans, etc. For the most part sort of fills in the gaps. But of course, you know, naturally one is learning from life. You're learning from patients, you're learning from other colleagues, and so forth. But there's no specific formal training for a lot of primary care, you know, understanding or knowledge. Well, as with any patient, of course, the procedure is a clear, concise history, trying to understand if there's an organic cause, an actual physical ailment, or, as you say, if there's actually a mental health issue, and then of course trying to think how one can best address that depending upon the severity of the case. It may just be a case of arranging some counselling for the individual, even just lending an ear. I think sometimes one of the things that I think junior doctors most struggle with when they move into primary care from having worked within the hospital sector is that it can be immensely cathartic to individuals just by being there, just by listening. I think within a hospital sector you're so used to dealing with the patient, but primarily, you know, a liver, lungs, it's very organ centered in that respect, that people lose the human touch, if you like. And we are all sentient beings, we are all emotional, and therefore we need to share our emotions quite often to make sense of what's gone before.
Do you physically have the time as a doctor?
Well, that is the $64,000 question, because every patient is automatically booked a 10-minute slot with the doctor. By the time they've come in, they've found the room, they've taken off their coat, you've said hello, you've introduced yourself, etc., and then you reverse the procedure. That 10-minute consultation is perhaps down to maybe 6 or 7 minutes. If a patient comes in and they say, "Doctor, I feel suicidal," you've got 6 minutes to do a suicidal consultation within. Therefore, I'm sure you can see logistically it is difficult to do. It therefore means that really you're sort of where you can during your whole day, some consultation you're going to be literally trying to get them in and out of the door as quickly as you can within reason, because you know within that working day you're going to have some patients who are going to need much more besides the booked 10-minute slot. So you're constantly sort of trying to make holes or make additional time for what comes almost invariably later in the day.
In terms of having such a short time span, this perhaps not in your case, but in the whole medical profession across the country, across the world, within a relatively short time span, is medication seen as a kind of quick fix, or how
Yes, I don't think medication is seen as a panacea or quick fix. I think everyone accepts that medication itself is not a curative agent. It simply is a way of buying time. It puts someone almost into an emotional state of limbo whilst waiting for things like counselling or possibly CBT, cognitive behavioural therapies, which we know are arguably the most beneficial for a lot of mental health issues, to become available. And of course on the NHS, waiting for to see a counsellor can take certainly weeks. Waiting to see someone for CBT treatment can even indeed take months or indeed longer. And I think it's very regrettable and profoundly, or I should say professionally, very challenging, because we know that our patients require and need these things, but we can do nothing to expedite or to, give them what we would like to be able to give them, what they actually need.
Who's in control of that then, when you say it's out of your control?
Well, it all comes down to fundamentally resources, and of course resources cost money. And of course at the moment, under these current financial constraints, the NHS is making 20% saving costs. Historically, over time, mental health has always been very much the poor brother, drastically underfunded compared to a lot of other healthcare areas. If you look at, say, such issues as cardiac issues or indeed cancer care, oncology, they've been very much the favoured forms of funding over the years, whereas mental health has been starved.
What actually chemically is going on in the brain? Or
well, chemically, as far as we know, there's an imbalance. There's a lack of what we refer to as more happy neurotransmitters, and so one feels down. One feels very low in mood, and the medication, for want of a better word, is almost like a supplement to try and sort of boost that sense of inner happiness. The difficulty is, of course, that the reason that person's come to see you is over the preceding weeks, months or years, they've arrived at point B. There were no quick, easy fixes. Medication takes really a minimum of, say, 10 to perhaps up to sort of 28 days to see, a response to medication. And of course, these medications invariably have side effects, whether they be short-term or long-term. And so one will always start off with a low dose of medication to avoid side effects, certainly. But it does mean that you're titrating the medication dosage to the patient's response to the medication. So invariably, because these are slow, long time frames, it's naturally difficult for the patient to often work with a doctor, because they've come in, they want something doing, and they want it doing now. Particularly in the case of men will often come in when they really are absolutely backs to the wall. Often they are dragged in or brought in by their better halves. Women often will present at an earlier point, and so one's naturally trying to get a quick response to very distressing symptoms, but it's a slow game.
What does nature provide, or could it, to light or?
Well, I think a lot of it actually, for me, comes down to more or less a sort of a cultural conflict between how we view how health systems have sort of been formulated over the years. Very much the Western approach is very organ focused, very disease focused, and to a degree the patient is rather lost within that. If you're looking at more sort of Eastern practices, it's much more of a holistic nature. One's looking at the whole individual, the whole patient, and indeed, if you're looking at that, you've got to look at also the ripples as well. And of course, the ripples involve the patient's dynamics, whether it be a work dynamic, a family dynamic, etc., etc. And I think also, we are, although we choose for the most part to divorce ourselves from nature, it has to stand logic that if we are animals, albeit we have scope for lateral thought amongst other things, we are still animals, and so nature, Mother Earth, has to be a big part of us. And I think certainly one of the things that we'll always say to a patient at the initial consultation, apart from consideration perhaps of medication if required, consideration of counselling, would be simple things like diet, exercise and sleep. These have always stood the test of time. They're very much common sense approaches, but test of time, of course, says it all, really. And it is always difficult, of course, because when someone is depressed, they don't have motivation to want to engage with anything. But it is very much chicken and egg. But certainly exercise, we do believe has a very beneficial effect for the individual. A GP, a lot of the time, we are a signposting service to try and refer someone or signpost someone to maybe a more appropriate service, whether it be within secondary care or indeed other primary care services. But obviously we are always going to be, for the most part, that patient's primary caregiver. Although of course over time continuity of care has been sadly lost, we are still, as a service provider, we are their first port of call. And I think, like most people, I think everyone at some stage in their lives has had elements of depression. Of course, depression is a spectrum from feeling, feeling down one day perhaps, to the person who really, on the far side of the spectrum is feeling suicidal. So I think everyone has felt down at some stage. The difficulty is that there's such a stigma attached to depression and mental illness. Even the word sounds awful, that of course people don't talk about it, which is a shame, because really talking is a very important and very therapeutic modality to help people. And over time, because we've become smaller units, we've lost the extended family, and to a degree we've also lost that sense of neighbourhood and families and so forth, and that I think has caused and has contributed to mental health illness in society.
How do you stay afloat? Like, how do you stay above the...
Yes, I think it's an important point, because I think, if you're seeing 40, 50, 60 patients a day on occasion, that's a lot of people. And, naturally patients, often when they come to see ourselves, they may have had a lot of angst, not just mental health issues. There may be issues of anger, and patients, we are there to be seen, to be held accountable for whatever it may be, whether it be social services or anger with their politicians or whoever it may be. And so we do get the occasional shouting episodes going on of people taking out their frustrations, having a bite. But one has to understand why it comes about. It's not aimed directly at you, it's just general frustration and anxiety that this person perhaps feels. For me personally, I suppose I try and exercise as best I can, and I think I'm fairly good at compartmentalizing. My work is my work, and when I go home, I'm back home to my family and so forth. But yes, whatever one does in this world, we all have to guard against and look after our mental well-being. Unfortunately, for the most part in the West, we pay lip service to this. We don't look after our mental well-being. Stress and anxiety are rife, and it's only a short step from that into more depressive issues. To
attach to the swimming element, and you've now had a chance to watch the...
Absolutely.
Is it
yes.
possible to...
Yes, I've not only watched it, but I was actually very lucky to also be able to attend the film premiere, which was a very enjoyable evening. I think everyone had a great time, but I think it is a very motivational, very inspirational story. A gentleman who lost a very close friend of his under very tragic circumstances, and it's about how he managed to, regain his sense of balance when he was, in a state of free fall, in a turmoil, and I dare say not spoken about, but there must have been quite significant impacts on his own family as well, particularly his wife, with obviously young children at the time. But the gentleman in question, David, he's done fantastically well, not just swimming 300 odd miles, but really it's about how he's managed to use external things to really help himself, because I think one of the concerns that a lot of doctors would have, particularly in primary care, is it's a sense really of a, almost culturally, a pill for every ill. There is no such thing. And I think we as a society have more or less abrogated responsibility for ourselves and those around us quite often. But I think we have to in some form or shape, take back a lot of responsibility upon ourselves. Life happens, whether it be good or adverse events, and of course it's really how we deal with those that sort of, show our mettle. And this is certainly a very inspiring story. I think, like all these things, when someone is in the eye of the storm, the first thing, of course, is not just providing help for them and signposting, but the question that will always be levelled at someone is, first of all, you don't know how I feel. So there's an element of sort of credibility, and being able to provide a DVD such as 300-mile swim to patients to either take out of a surgery or to watch whilst there, I think is a very valuable tool to them, because they can identify with, and from that point of view there's an empathic message coming through from the DVD, coupled also with assessment tools, whether it be a one single step, using their assessment tool, or indeed even downloading, watching the video on the website, to also, of course, like most websites, accessing anecdotal information, other stories, experiences, because although we like to think of ourselves as islands, we are all connected, and to a degree, the more that we can connect ourselves together, we become a stronger chain. The strength of a chain is defined by its weakest link. So the stronger we can make ourselves, both individually but as a society, the energy that comes with that, has to lift us all up.